Oh, sorry.
Here's the lawyer.
No, we're not saying. It's okay, lawyers are good.
Well, good morning, everyone, and thank you for being here. We'll call this meeting to order. I know that we are anticipating a full house today as far as board members go, and so a couple may be trickling in just a couple of minutes. But until then, let's start off with a roll call of board members. I'm Ted Colas, and of course, I'm here. I'm going to start with Doris Ralston,
I'm here.
and Dr. Terbush,
I'm here, thanks.
Commissioner Lojinos Gonzalez.
Here.
And Dr. Richard Vu,
Here.
and General Jack Rigg.
Here.
Thank you. Okay, and I see coming in is Commissioner Cammie Bremer. Also present. All right. Hopefully, most of you have had an opportunity to look at the agenda, and if you haven't, take a moment now, and then I'll need a motion to approve the agenda in a second.
Motion to approve?
Second.
Okay, motion from General Briggs and second from Doris Ralston. All in favor indicate by saying aye.
Aye.
And that is unanimous. Board of Health comments is next on our agenda. And there are a couple of things that I would like to mention here before we get started. I'm going to take the liberty of going first. First of all, our community, particularly in Fountain, but really all around the area, is saddened by the loss of Officer Julian Becerra, where that was just a horrible event that resulted in that police officer's on-duty death. And for him and his family, I just want to express our condolences as a board and say that our thoughts and prayers are with that family as they try to navigate these very difficult waters. The other thing I'd like to mention is that great humanitarian crisis going on in Turkey and Syria. After the earthquakes there, you can imagine what those communities are going through when they're recording now up to, I heard last night, over 45,000 deaths as a result of the, right over here, Glant? Right over here. As a result of the earthquake. So again, thoughts and prayers going out to those communities. They're very, very far away, but I think that the people in this room, the people that work for public health, can kind of appreciate the devastation that those earthquakes have caused and what those communities are going through. And I see Councilmember Donaldson coming in the room, so it looks like we are filling up our dais up here. Councilmember Donaldson is now present and just walked into the room ahead of Councilmember Donaldson is our newest Board of Health member, Glant Havenar. Did I say the last name correctly? Havener. Okay. Glant is the mayor of Palmer Lake, and I had the opportunity to join our two county commissioners, Cammie Bremer and Lojinos Gonzalez, with an interview of two very qualified candidates. As a result of those interviews, Glant was offered the position, and I understand yesterday the county commission voted to have Glant join us on the El Paso County Board of Health. I'm going to, during this portion of Board of Health comments, I'm going to give Glant an opportunity to introduce herself to the rest of the board, introduce herself to many of our employees that are in the room, and just give us a little bit of background of who you are and why you're joining us.
Thank you. My name is Glenn Hager. I am the mayor of Palmer Lake, and I had sat on city council for about 8 years and then decided to run for mayor. My background is in real estate. I'm a managing broker at a local real estate firm, and I have 3 children who I'm earning every gray hair. I have 2 out of the house, 2 adult children, and 1 left at home. Our baby at home is a junior at Palmer Ridge High School, and we spend a lot of time dealing with teenage issues and sports.
Okay, Glenn, thank you for joining us. And as I understand, this is the first time that we've had a representative from the Palmer Lake area, so
It is, I'm excited about that.
we're very glad to have you. We'll go around the dais. Anybody else who would like to make any opening comments? We'd sure love to hear from you. Commissioner Gonzalez.
Thank you. I just wanted to highlight that we do have a regional opioid council meeting, I believe, on Monday at 1 p.m. So several of us are members of that board. So
Okay, thank you.
Nothing.
I do.
Yes, General.
Jack Briggs, for the record. I am bringing up to this board awareness for a House bill that's coming to the. I got to get the committee right because it's one of those funky names for a committee. It's the Public and Behavioral Health and Human Services Committee. And the bill is the Overdose Prevention Center Authorization Bill. And what the bill is intended to do is give municipalities the authority to establish safe injection sites within their municipality. This is something that Colorado doesn't have, and they're attempting to give this authority. I'm speaking today in opposition to this as a provider of services to those that are addicted. 24/7, 365, we're watching folks that are close to or overdosing outside of our facility. We don't allow drug use at the rescue mission. I think this board needs to be aware of this. What I would like to say is the shared value of everybody involved in this is we want people to stay alive. There's no contention about that. I do believe that this is a misfocus. And I'll just say that as opposed to trying to talk about this from a passion, emotion perspective, let me give you just a different perspective. There are a few of these sites in North America. The first one was in Vancouver. It started in 2003. One of the arguments proponents will have for this is that overdose, that no one's ever died from an overdose in one of these facilities. They're now in New York as well. And that's true. The highest rate of overdose in British Columbia is within a block of the facility. And it's because of this. It's logistics. When you have a safe injection site, you have to bring your own heroin. Where are you going to get it? You're going to get it from a dealer. Where are the dealers going to set up? They're going to set up near the injection site. That's what's going to happen. Now, an injection site can have 12, this particular one in Vancouver has 12 seats, and they can do about 600-700 people a day. That's about under 10% of the number of people that are using heroin within a block of that facility every day. And so all the fentanyl, all the things that should be tested for with compassion, all these other things go out the window because people are just getting their drugs in that place because you've created an environment of incentive to go there. Right? So it's just logistics. I'm not talking about the compassionate empathy, all those other things that are out there. I'm talking about the logistics of how people use drugs. And so I believe this board should consider those things very seriously about if we were to ever have this type of idea in El Paso County, Colorado Springs, in these areas, because I think it is a detriment to health and safety in our community. Thank you.
Thank you, General. That's very good information.
It's House Bill 23-1202. It'll be in this committee on next Wednesday. I plan on attending that and speaking as a citizen.
Thank you. Dr. Vu.
Can I
have a response to that. Number one, before that, I wanted to, if okay, recognize Dr. Robin Johnson is in the house.
Oh, yes.
Right.
Safe injection sites. So I myself am not in favor of safe injection sites. However, that is really based on the arguments that's in my mind without really knowing a lot of things. And if it's true that, and it is true that there are established safe injection sites in the country, there must be some data out there that we can gather. And it would help me if we have some sort of presentation either from our team or from our medical directors about just the data of risks and benefits of safe injection sites. Because right now, just for me, it's just, hearing other people talk about it, and I think about risks and benefits in my mind without really knowing a lot of data.
There is a lot of data. One of the things that's hard to find is the transfer rate of folks who are coming to a site and then seeking further medical care. The numbers are low, but because they're low, it's hard to get that data. Folks aren't publishing very much of it. I will tell you that the highest rate of overdose in British Columbia, this started in 2003, and the highest rate of overdose was 2021. So it's I don't know, just anecdotally, something is amiss.
Thank you.
Any other board comments? Seeing none, we'll move on to the approval of the minutes. If you've had an opportunity to look over the minutes from last month's meeting. And for this, I'm going to need a motion and a second.
Yeah, Mr. Chair, I move approval of the board minutes.
Okay. Councilman Donaldson moves for approval. Do we have a second?
I'll second.
And Dr. Terbush has a second. All in favor say aye.
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 Any opposed or
I'm just abstaining because
Abstaining?
I wasn't here for those minutes.
understood? And so Glant has abstained from that vote. And otherwise, all voted in favor. Okay, moving on to public comment on items that are not scheduled for the agenda. Looking at Vicky, we don't have anything online. Anyone in the room that would like to make public comment? Okay, seeing none, thank you all very much. We will move on to the Public Health Champion Award. And I think we have some people here to accept this award. And Susan, do you want to introduce it? Do you want me to?
Sure. Why don't we go ahead and tag team? And we also have a video that is provided by City Hope. So let's go ahead and since Dr. Robin Johnson is in the house, please come up first. She is one of our public health heroes for those that know her and might be just getting an introduction to her. She is with City Hope, and she's a consultant for strategic development of City Hope. And I'd like also Mark Wester, if he's here. He is with Embrave. He's the executive director. Natasha Harrell, is she with us? Natasha, okay. And Natasha has been so wonderful too. So it's please pass along to her that her excellence and customer service in working with us is just phenomenal. So too bad that she's not able to be here. Sue Cooper, is she here? Embrave, she's with Embrave, Client Services Director. And I think we have everyone representing City Hope. So I'm going to go ahead and just give a little bit of information about why we are honoring you today. And then we can play the video, and then we can also take some comments as well. So our our community disease prevention and control is one of the foundational services provided by our agency. An important public health tool to stop the spread of infectious disease is isolation, which separates people who are sick with an infectious disease from other individuals. Unfortunately, some in our communities do not have a residence in which they can safely isolate and recover. In August of 2021, Brave partnered with the City of Colorado Springs to develop a temporary facility to provide isolation for COVID-19, as well as other infectious diseases and overflow family sheltering. Since that time, City Hope has been a critical partner in assuring people experiencing homelessness have a safe and supported place to recover from infectious disease and prevent further transmission to other vulnerable individuals. From August 2021 until City Hope concluded its mission on February 1st, 2023, the facility provided isolation and quarantine space for more than 600 individuals, including 493 households. City Hope has been instrumental in helping prevent the spread of COVID-19 among the sheltered and non-sheltered individuals experiencing homelessness here in El Paso County. And even beyond the community disease, we have encountered some challenges with zoonotic diseases and very complicated cases that City Hope, without their help, options are extremely limited. And so it's unfortunate that City Hope is closed, and hopeful that I believe that some opportunities are being looked into related to how to maybe restart and regain. But it is one of the most critical assets to our agency as it relates to the partnerships that we have in the time that we spent together for individuals. Very complicated cases, and just want to say thank you so much on behalf of our agency and our staff, our data analytics and our community disease, and also our Deputy Director, D. Rand Ryberg, who oversees our community disease. We greatly appreciate you all, and Natasha as well. When we had the fire at I think it was called the Region Agency, and there was a lot of senior citizens that didn't have a place to stay. Natasha I heard, she was out in her car. She got a phone call from us, and she regrouped, in the evening because seniors were displaced to try to find them a home. And this was a while ago when they had the fire, but we could talk about so many situations where you guys have been phenomenal partners and leaders in the community. So thank you so much. If it's okay, let's go ahead and play the video, and then we'll take comments. Does that sound okay? And the video is about 5 minutes. Okay?
I know this city needs a lot, but this homeless problem, it's becoming huge.
People don't realize how bad the problem is. They don't see how many people are in trouble.
You're seeing families, and not just men, because that's what you expect when you hear homeless. You think homeless men. You don't think 3-year-olds, 4-year-olds, 7-year-olds, women.
The homeless people, you see them on the news, you see the things that people do that aren't all of us as a whole. But, when you see that on the news, this homeless camp this homeless camp that, these people here, I think the whole city starts to lump us up in a big black bowl of oatmeal, we're all bad people and we stay away from them.
They look at you because you're homeless and they feel it's because you are alcoholic or a drug addict, or it was caused from that sort of situation, and that's not the case with half these people here. It's not. It's just life happens, and that's what it is. Life happens.
My husband was he was self-employed, and I did babysitting jobs. And so once COVID hit and people weren't really sending their kids to the babysitter, and he wasn't able to get any more musician gigs and stuff like that he was doing, the employment really the finances hit us hard.
Hard times hit us, and we weren't able to pay rent, and eventually, homelessness, ensued.
Once I got diagnosed with the cancer and stuff, it's been rough. And then I ended up going to prison for 2 years, and lost my mom. My mom was already gone, but I lost my dad and my little brother. So.
My husband was murdered at Arcadia Park, and I developed cancer. Had to go through chemo and radiation, lost my job, lost my home, and here I am.
I feel like City Hope has been my rock, honestly. Just how amazing they are and how helpful they are.
This shelter has taken us in as if we were family.
You have teams of people that will connect with other teams of people that connect with other teams of people that just want to get people off the streets.
They're just all about making sure that we're safe and that we feel safe. And the staff here is just amazing.
My husband's working again. He has a full-time job now. They helped me get a job. I mean, they've helped my family in so many ways that I'll never be able to tell them. Thank you just to me, don't do it. Because they have become my family.
Every single staff member I've met here wants to help, wants to do what they can do for you. You know, so the resources this place provided are the resources that we really use to help us get us here. We would not be here unless we had the help, the major housing help, because we have a place to live on top of having someone helping us to find another place to live.
If it hadn't been for this place, man, I'd be probably screwed, man, because I don't know where to go.
They helped us get our birth certificates, social security cards.
I didn't read any of this.
Wow, City Hall. They helped us with a lot of stuff. Yeah, they really helped us with a lot of stuff. And if you think about the time frame, wow.
I'd have to say, for them opening their doors and letting people with families like us to have a place to come and lay their head and not have to worry about having a tent or going to somebody's house and begging, can I stay the night here or can I take a shower? So yeah. Just being open and allowing families like mine to have a place to be in this time of struggle, because that's basically what it is, it's a struggle.
My baby was born, I was supposed to have him on the 18th. My baby was born July 16th. They came and seen me. They came and showed them love. I got diapers and clothes. My kids, they got new shoes and some clothes and some jackets. They helped them get their schools. They helped them get their schools. Wow. They really did a lot for us. And they didn't even know me that long.
I think if there would be one thing that I could change to help others in this same position, or even worse, I think I would love to be able to find a way that could help fund places like this. Because this place works, it helps, it's real.
We are people with feelings, with families. We just need a little help, a little helping hand, a little push somewhere. Say, hey, these people are worth it.
Well, I think that video spoke very loudly to the work that City Hope does. And if you all come forward, and I want to hear from any members of the board that would like to comment on this. General.
Jack Briggs for the record. And I just want to compliment, lift up, praise, whatever the best words that I can possibly say for the team over at City Hope. At Springs Rescue Mission, we're focused on those that are unaccompanied, and we don't have the legal authority to have children because of some of our clients. This community is different because we do have organizations that come together and fill in the needs, particularly for families. This was the case for City of Hope, also with a case for isolation. Mark and his team, I just want to compliment you for stepping up, for being that leader in the community that allows Colorado Springs to be different. And it's because of folks like you. And Robin, thank you as well. And, just the compassion and the willingness to step into hard things. So thank you.
Any other board members? Well, I've got some notes that I'd like to go over. First of all, it goes without saying that you were reliable partners. You were people that, an organization that so many people could refer clients to from a wide variety across our community. People could go to you for help. And the care coordination, we heard a lot about that on the video, how you brought different entities together to help those clients that you have that were residents with you. Medical care, food, other resources. You're able to bring all of these things together to help people. And you're helping a segment of our population who often doesn't have a voice, who often doesn't get heard when they are expressing their need for assistance, but you listened, and we greatly appreciate the way that you not only listened, but you put what you heard into action to care for people, and we're very, very grateful for that.
And I wanted to mention, too, I mean, you guys are well aware, but infectious disease knows no boundaries, and they do not fit within a Monday through Friday, 8 to 5 time frame. And so City Hope, was available really 24/7. And also, as General Briggs had mentioned, that Springs Rescue is a strong partner with City Hope, but there's limitations in different shelters. And so City Hope also took families and pets. So there's just a lot of areas where we relied so heavily on the partnership, and it is a critical partnership. And so that's why we are celebrating you all today. And also, we're going to hear a little bit later about our care coordination and our coordinators and what we do in the community, because the public health system, it's symbiotic on so many different levels, because one agency, we just can't, work in a silo or get things accomplished at the highest level optimally if we're not working with partners. So wanted to mention that, and please, if you have any comments, would love to hear them.
Yes. Good morning. Mark Wester, Executive Director of Embrave, and thank you for this honor. When we started this, I wanted to highlight the role of the health department and other partners in this. As I was watching the video, I was thinking, there was a lot of people supporting Embrave and City Hope in this. This started really as the pandemic was getting started. Natalie Gaillou, who was a staff member, she reached out and she started working closely with myself and my staff around how do we handle COVID in the context of community corrections or congregate care. And she and I worked together for nearly a year. And that was a context in which the city came to us when they needed isolation shelter for COVID. And it was because of her partnership and the relationship we'd built with Natalia, and also Mary Nee Clabber, that we felt confident to step into the space. And Peak Vista and other community partners, Springs Rescue Mission, Diversus Health, the city of Colorado Springs really rallied behind this and made it possible. And I want to say thank you, because if we had not had that partnership early on, City Hope could not have existed. All Embrave did is we brought our knowledge of how to care for difficult populations and challenging populations and care coordination, and brought that to bear with the new population. So thank you very much for the recognition and the partnership. And I'm really proud of our community, the way we collaborated together. Thank you.
Great. Anyone else?
So I wasn't going to say anything because the meetings get long, I know. But I have to say what a pleasure it is to be in your house again and to just acknowledge what it means to partner with public health. I have a kind of a passion about outbreaks. My husband thinks I'm a little weird that way. But to be able to partner in a way that's meaningful and for public health and the work, I just know that your staff is exceptional. They are compassionate and they're looking at what are the best practices, not just an easy solution. And City Hope did step into this gap during a critical period and became sometimes, I think, the easy button, but mostly they were really creating the best solution, bringing together all of those integrated services. And as Mark spoke to, doing it with partnership and even like the homeless outreach team from the fire department, right? Through that CARES department and all of these things coming together. But then that ability to communicate real time with your staff. So we took on COVID. We ended up having families because homeless families are affected by COVID. And then once you have that population, the ability with these services that Embrave brought to bear to get them housed, right? I mean, it created a secret sauce for success. But then we were poised to take on some Shigella. We talked about TB, some complicated TB cases. We took on some complicated rabies cases and got to work with environmental health. So Kat McGarvey, I don't think if she's here, but your environmental health team worked with us to successfully be able to house not only the individuals that were in need, but their pets in a way that was compassionate and provided safety on that campus. So I could go on and on about the import and just the I think the success of such a program. And so while that funding has ended and we have closed that, know that we have proof of concept here as a community about what can work. And so that vision, we are working to continue to promote that, and we expect to be working with public health in this realm in the future because we know that you guys are the champions of creating these kinds of solutions that are collaborative, sustainable, and successful. Thank you.
I'd like to just take a brief moment, and not to wear out my welcome, but I want to recognize Sue Kuiper, Dr. Sue Kuiper, who is our Client Services Director. Natalia, when the city had talked to us about opening City Hope, and I said, well, and they said, when could you get it open? I said, well, give me a couple of weeks to put some things in place, get it ready. And 4 days later, I was actually traveling in the Midwest, and my phone rang, and my cell phone rang, and it was Natalia, and she goes, we just had an exposure of 11 homeless individuals exposed to COVID. I know you're working on getting your program, the isolation shelter, up and running. How quickly can you do it? And I said, well, let me make some phone calls and get back to you. I called Sue, said, hey, couldn't get her, give me a call back. And when Natalia called back in about an hour, she goes, well, could you open today? And I said, yes, before I'd talked to Sue. So when Sue called me back, I said, can we open City Hope or the isolation shelter today? She goes, yes. And I said, great, I just committed us to it. I will tell you that a dozen of our community corrections clients helped, came over and helped, and they wanted to get the building ready. Sue pulled a lot of our staff together, and in 6 hours we opened the program. And it taught me something about Embrave and our staff. And so I want to say thank you, Sue. We couldn't have done it without you. And thank you again.
Well, we certainly appreciate you. Everybody, We do have an actual award for you, and Michelle, photos? Okay, so if you'd come up here. We've only got one star, there's 3 of you, so they'll have to fight over it later, okay? If you'd come around, and we'll take a photo with the backdrop.
Okay, here we go. Okay. Here we go. Front and center.
Guys, they were color coordinated, all blue.
Good to have you here. Welcome. Yes, we got snuggle up here. Okay.
All right, I'm just going to take a few photos.
Thank you. Thank you so much. Congratulations. Thank you.
Thank you so much.
Don't stay away.
We had just started the presentation for City Hope when Council President Tom Strand walked in, friend of this board. Thank you for being here. And now we are ready to move into budget and finance presentation.
Good morning, Samantha Montmany with El Paso County Budget Supervisor for Health and Human Services. Thank you. So before you guys is the preliminary December information. This is preliminary. It's still going through audit and all of the final steps, but right here is preliminary for you guys. As we've kind of anticipated and what's been happening all year, revenues have been coming in slightly under budget, and that's again due to the expenditures coming in under budget, which is again due to vacancies and whatnot. So some things I really wanted to point out, the ARPA, the El Paso County ARPA, what's happening with that one right now, we have received the funding. However, with accounting principles, you have to record your revenues in the same period as your expenditures. So we just didn't have those expenditures this period. We are budgeted and plan to spend that money in the next 2 years, which is what we have to use it. So I just wanted to point that out, yes.
I'm sorry, can you clarify which fund is this again?
The ARPA from El Paso County, the ARPA funding, it's third one down.
Gotcha.
Can you please, what is ARPA?
American Rescue Plan Act.
Okay,
Thank you.
thank you.
Still $65 million left.
So this is where the county has been very generous and supportive with us with that. But I did want to point that out. Like I said, we've received the funding. However, due to accounting principles, we have to record the revenues in the same period as the expenditures, which will happen in the next 2 years. We'll spend it all. Again, the ELC grant is slightly underspent. Again, that one's a very restricted funding.
When you're speaking, could you just say what the acronyms mean? Because it's kind of a foreign language probably for
Sorry. Of course. The Epidemiology Laboratory and Capacity Grant. Yes. I'm working on that one. That one is coming in under budget as well. Again, that is due to that grant is very, very specific on what type of expenditures and what items it can cover. So that's been part of the problems with that grant, as well as, again, we've had the vacancy savings. It's a reimbursement grant. So as we don't have those expenditures, we're unable to draw down that reimbursement.
And I did want to mention, just as a refresher, I mean, we did have to do a reduction in force with the Epidemiology Laboratory Capacity Grant, because when this grant funding, the concept came around and funding for us, which is reimbursable for the work, it heavily relies on investigations and contact tracing for COVID. Now, it doesn't make sense for us to utilize the funding if our, at a certain level, if the case counts and everything is going down. So as the work decreased, then that's that's a challenge with some of the grants, that they're very specific, limited, and so I just wanted to point that out, that it has to make sense and we have to be prudent with the dollars, but wanted to provide that refresher.
Another thing we wanted to point out was the license fees and permit. There's been some struggles early on in the year with the program changes, but that one's come in pretty darn close to budget. I think it's about less than 1.5% off. So just wanted to point that out. Everything is moving forward and going well with that. Overall, we originally budgeted to go in slightly into fund balance, but right now we are actually anticipating not for 2022. Any other questions?
Just for the board members here, I had the opportunity to ask you about our fund balance and the health of that. Could you restate that for the rest of the board?
Yes. So our fund balance at the beginning of 2022 was about $8.6 million. So that percentage, the fund balance policy of Board of Health would like to stay within 18 to 21% of our current year expenditures. We are within that range, slightly a little bit higher, but so we are in a very, very good place right now with our fund balance.
Thank you.
Yeah.
Questions from the board?
Are you going?
No, that was informational. In the past, you had asked for a month over month, and so that's all that was, is just presenting each one of these kind of together month over month, so you can see the changes.
Thank you. Can I say that it is very helpful for me, and thank you very much. And the way that I interpreted this was that there's no unusual trend, at least over the 12 months, and expenditure is still lower than the revenue, like you said. And one possible reason for that is staff shortage, et cetera. So therefore, my interpretation is financially we are healthy. In cash flow, we are healthy. And we have appropriate days cash of hand, days of cash on hand, and that the difficulty might be in operations, even though finance affects operations, operations affects finances. The difficulty in our organization at this time is really staff shortage in operations.
Yes.
Thank you.
Any other comments? Thank you very much for the presentation.
Thank you, guys.
Okay, I believe that brings us to the director's report. Turned over to Susan Whelan.
Okay, thank you. Wanted to mention that we are working on our 2022 budget book, which is a significant effort that we're involved in with finance and budget. So more to come on that will have a lot of details to refer to and will be public as well on our website. So that is a tremendous amount of work that we're reviewing 2022 financials. So I would like to highlight this month our care coordination program, and I'd like our program manager, Emily Maney, to come up. She is with Maternal Child Health, and also Maggie Yokohana, who is our health equity planner. And I know that we have some care coordinators here, all of our care coordinators here as well. So as part of the presentation, we'll introduce everyone and share the phenomenal work that they are doing in the community on behalf of our agency.
Thank you. Is this on? Yes. Okay. So good morning. My name is Emily Maney, and I'm the Maternal Child Health Program Manager in our Community Health Promotion Division. And I'm here this morning with my team to talk to you all about our care coordination program. I'll get us started with an overview of what care coordination is, and then I'm going to hand it off to Maggie Yokohana, our health equity planner, to go over some of the program data from the past year. Just to give you some background, our agency has done care coordination for over 20 years for children with special health care needs, which has provided a really strong foundation for developing this new care coordination program and has allowed us to open up these services to other populations in need. The care coordination program is grant funded. We've pursued a variety of grants to keep these services going, starting with the Protect Our Neighbors grant in 2020, and then the CDC Health Disparities grant, and looking for the next 5 years, our CDC Workforce Infrastructure grant. You can go to the next slide. So this is our team. We have Erin Gilmore with us, Bertha Castillo, who is our bilingual Spanish-English coordinator, and then we've got Jamel Powell, and you'll be hearing from all three of them in a few slides, so I'll let them introduce themselves at that time. Our care coordination team helps individuals and families navigate complex social service and healthcare systems so that they can access critical supports, services, and resources. And I'll discuss what some of these services and resources are in a few slides. This work ties into the mission, vision, and values of El Paso County Public Health to promote and protect public health and to work towards a community where every resident has the opportunity to achieve optimal health. Next slide. Our coordinators take a personalized approach that is focused on the unique needs of the individual or family that they're working with. They help to identify and mitigate barriers to getting care and services, and they develop an individualized treatment plan based on what the client or family system needs in order to thrive. And we receive referrals from individuals through word of mouth, at outreach events that our team attends, as well as through our vast network of community partners. Next slide. So this is a depiction of some of the resources and services that the coordinators help with. Housing, as you'll see when Maggie presents the data, is a huge need in our community, and many of our clients are either experiencing homelessness or are on the verge of losing their home. Coordinators also help people find financial support to pay their bills, connect them to the workforce center for assistance in finding employment, provide them with resources for childcare, connect them to food pantries, and help them access physical and behavioral health services, just to name a few. As you can see, there are many unique needs that our team can assist with. And on the right-hand side, this is one of our flyers that we use to promote the program. So I'm going to pass it off to Maggie to tell you more about the numbers side of things, and then the coordinators themselves will share a few stories of how they've helped the residents of El Paso County.
All right, thank you. So I'm just going to give a little quick one-year recap of what our team has done. Starting at the beginning of the year, they got their first referral back in February of last year. And they got about, within that beginning of the year, about 130 referrals, and a lot of those did come from our communicable disease program through COVID cases. And this is when our team started really working on outreach efforts. Moving into the summer months, the referrals slowed down a little bit, but that's, again, when our team, our care coordinators, really amped up their outreach efforts and made about 122 new contacts, and that's with community partners, leaders, organizations, and services. And this is also the time that they worked on a very expansive community and behavioral health resource list to provide these individuals. And so moving into fall time, that's when the referrals started coming in through those outreach efforts. And so they received about 200 referrals. And then by then they had finalized their resource list to about 260 community resources that were active at the time, which was great, as well as 115 behavioral health providers that were available for those seeking behavioral and mental health. And then by the end of the year, they received about 300 referrals. So a lot of that snowballing effect of outreach effects and efforts really came to fruition. And they also kind of started expanding out into other efforts such as monkeypox response. And then they also got to do a little bit of workforce development by attending the Public Health in the Rockies conference. And so all of that ended up being about 715 referrals that they took on. And 15% of them spoke Spanish only. And so having our bilingual care coordinator was a huge asset. And again, throughout the year, they made 255 new points of connection, again, with partners in the community, and they were able to distribute 720 COVID-19 testing kits. So on our next slide, I'm just going to go over a little bit some of those needs that were identified through those 715 individuals. So we found that nearly 1 out of every 2 faced at least 2 high-need barriers or complex issues. And so, as mentioned before, housing was the highest identified need. And so that broke down to either struggling to pay for rent, utilities, seeking affordable housing, or experiencing homelessness. The second most common need identified was food access. So 1 out of every 5 individual that was seeking care had expressed issues looking for affordable food, getting connected with food assistance programs like SNAP, and even just having enough food at home during sickness or isolation. And then the other barriers that were identified included accessing COVID-19 resources such as testing kits, treatment, or information, finding childcare or baby supplies, just paying for general bills or financially struggling, accessing behavioral health services. And then we did get quite a few of those aging population, our seniors seeking care, as well as transportation. And on our next slide. So this is just a touch on some of those stories, some of the successes that our care coordinators were able to connect, again, from start to finish with a lot of these individuals. So again, touching on housing, they had a family that was experiencing homelessness, and after working with one of our care coordinators, they were able to secure stable housing for the next year. And then on another case, an individual had called in saying that their electricity had been turned off, and this was in the middle of October. After, again, working with one of our care coordinators, they were able to get that electricity turned back on that day. Also, just again mentioning with our food access needs, there were 3 families looking for emergency food, and after, again, working with a care coordinator, they worked with Care and Share to get those emergency food boxes delivered that day. And then touching again another story with our senior population, there was an elderly trying to find transportation to their appointments and had difficulty. And so after working with our care coordinators, getting connected with Silver Key, they were able to get to their appointments. And so these are just a few examples of what our care coordinators provide. They also can provide bus passes to individuals, emergency food boxes, COVID-19 test kits, and then referrals to just other connections or other services that individuals may need. And so I'm going to go ahead and hand it over to our care coordinators to share their stories as well. Thank you.
Hello, everyone. My name is Jamel Powell, and I am one of our care coordinators. And the case I'm going to tell you about today really just highlights how our team really collaborates not only within our agency with other departments, but also with community members. And this story is going to sound a little familiar because it was just referenced by our City of Hope team as well. We had a case that came in with a family that was first came in contact with our communicable diseases team. The team said, hey, this family is homeless right now and they're going to need some extra support. There were additional complications to this particular case, which was referenced. They were able to safely house the family and their dogs in a way that was able to address the safety and health and well-being needs of the family, which was really great. But when working with this family, as it says there, the family's puppies had been exposed to rabies and they needed a safe place to isolate the dogs so that they can all remain safe. They were able to do so at City Hope. And while at City Hope, I kind of came in and also helped the family with navigating how do we resolve these issues of kind of you're homeless right now, what resources do you need and what help do you need? And with that collaboration with not only City Hope, Natasha and her amazing team, we also collaborated with Homewards Pikes Peak, in which the family had a housing voucher, Westside Cares, and even with making referrals to Nurse Family Partnership and other prenatal needs for the family to get them the resources that they needed. Now, within, I think it was about a 6-week time frame, this family was able to obtain permanent housing. Their dogs were able to safely quarantine and isolate until the concerns were resolved. And now that family has stable housing. And it was through that collaboration, not only within our department, but with those community partners in which we were able to really serve our community and resolve a major issue for this family. Thank you.
Hi, my name is Erin Gilmore. The story that I'm going to talk about a little bit today, I had an elderly client that was struggling a lot with her mental health, that was living with family. She has a very fixed income due to Social Security, and if you know Social Security at all, you're not getting very much. However, she really wanted to live out on her own, so I was able to kind of work with her funds as well as the area of town that she wanted to be in to connect her to a place that she could actually afford. If you guys may be aware, if you have ever rented or are currently renting, most places have a requirement of you must earn 2.5 to 3 times the rent. That's really hard when you live on a fixed income. So we were able to find a place that I could communicate with that was able to put those barriers aside and actually get her housed. And this place allows her to actually have some money left over every month. However, when you're going from living with a family where you don't have to pay rent to now you have to pay rent, your resources are now very limited as well. So I was able to find a couple other community agencies, one in particular, SRDA, also known as Senior Resource Development Agency. They're able to deliver home-cooked meals as well as transportation needs. Most transportation services will only take you to appointments. Otherwise, you have a really high cost to access that. However, SRDA does not have those type of requirements. So she could actually go out into the public and do fun social activities. So this is an individual that I'm still currently working with, and now we are working on the social aspect because she is still isolated now living on her own. But it's a wonderful success story in that you can afford to live here and you actually have some money left over. Thank you.
Well, good morning. My name is Bertha Castillo, and I'm the bilingual care coordinator. The client story that I want to share with you guys today is of an older Spanish-speaking individual that I worked with. He has very limited knowledge of the English language, and growing up, he didn't learn how to read or write. So this just was one of the barriers that he had to kind of alleviate or find solutions to some of his financial stress. So when I connected with him, one of his main concerns was his utility bill. He was past due, and he just didn't know where to start to pay his utility bill. And actually, after talking to him, turned out his electricity had already been shut off. And this was a big concern because he has some mobility issues, and he also has some medical conditions that made it very dangerous, especially during the nighttime. So our first step was to open up care coordination to allow him to give me that consent to provide some translation services and speak to some organizations on his behalf. So we first called Colorado Springs Utilities together, and we tried to find a solution with them and just discuss whether we can have his lights turned back on that same day, or just how we can have him pay his utility bill. They first told us we needed a doctor's note, so later I was able to help him do that doctor's appointment to find that medical note. And then we were referred to the COPE program, and I had to find a partnering agency for COPE, and so I called 211, and I was able to find a Spanish-speaking case manager for him, and we applied for COPE, and we had his electricity turned back on, and then also give him a big discount on his utility bill. Thank you.
Yeah, so thank you for having us, come speak. Are there any questions or anything else we can answer?
Can I? Miss Yukana, I apologize, I forgot your first name. Can I ask you a question in one of your slides? The slide with housing needs, food access, and others.
Yes.
And if you can please go back. So in my mind, I'm trying to figure out how big of a problem food access is, especially with increasing prices of food. So when I look at that, 51%, 23, and 26% adds up to 100. But in my mind, I'm assuming that there's an overlap.
Yes.
For example, a lot of people with housing difficulties also have food access difficulty.
Yes.
Can I ask you how big of an overlap that is? Do most people with housing problem have food access problem also, or very few?
Yeah, definitely. And I think our care coordinators can speak to that a little bit more. But yeah, that definitely goes hand in hand because, again, the bottom line is those financial resources that are kind of the highest barrier. So whether it's affording housing or affording food, there's definitely a struggle between the two.
Thank you. So maybe in my mind, then people with food access and your clients is probably more towards 50, 60% or so.
Definitely, yeah. Even when, so when looking at the overlap numbers, it's definitely higher.
Okay, thank you.
Yes, thank you.
Jack Briggs, 2 questions. So the first one is, can you just go back and explain to me, it sounded to me like what you said is that this was initially started for children with special health needs, but you're expanding it, but it looks like you've already expanded it in the first year. Is that correct? Or
Yeah, so at Public Health, we've had a program for care coordination for children and youth with special health care needs called HCP for over 20 years.
Okay.
And then when COVID hit and we got some CDC health disparities funding, we developed this new care coordination program sort of based off that model that we had with HCP before.
Okay,
Does that
so
help?
it does, because it sounded to me like you were going to try to expand it this year, but your team has already done a great job of expanding it, it sounds like.
Yeah, so we brought
Right.
this team on in February of
Okay,
last year.
all right,
So it's been about
understand.
a year since we've had them.
Okay,
Yeah.
and the second question that I have, particularly regarding folks that are housing insecure, is transportation. So can someone just walk me through what transportation resources you typically reach out to? I know there's Silver Key, obviously, when it comes to elderly, but what other services are out there that you are tapping into to help people to get to resources?
Yeah.
Happy to speak on that, Erin Gilmore again. So with our transportation, if it's something medical related, we are lucky in the fact that there's a lot of different medical transportation services. However, there's a caveat to that. You cannot take a medical transportation service to pick up your medication, although that's medically related. So we do actually have access to bus passes. So if an individual struggles with understanding how to navigate that, then we're going to walk them through that as well. Otherwise, outside of that, we can utilize programs like Good Wheels. You can pay a very small cost. Invita is also another wonderful transportation service. If you're over the age of 60, you can actually ride for free. So we just take our really expansive transportation resource list, take into account this person's circumstances, and give them something that makes the most sense. We try to make it free because all, if not most of them, are struggling with money. So we want to make sure we're not having to have them pay too much too.
Thank you.
Any other comments from the board? Councilman.
Yeah. Thank you. And is it Emily? Yeah. Emily, I think you mentioned that kind of the expanded program is funded with, or was funded with, some COVID money. Is that generally correct? When does that run out, and what's the plan? Do we have a plan?
So the CDC Health Disparities Grant that they're currently funded under will end in June of next year. However, we have the CDC Health Infrastructure Grant that will be continuing on for 5 years past that they will then move into.
Okay. And Board Member Briggs brought up kind of what I was wondering about too. It sounded like this started off pretty specific with children and what was the other group? But mothers. But now it's what boundaries are there now? None. I think I got the big zero goose egg sign from behind you.
Yeah, there are no boundaries now. And just to clarify, I think I was just saying that we have experience with care coordination programs with our children and youth with special health care needs program that had been funded through MCH for 20 plus years. And so when we got the opportunity through COVID funding to create a care coordination program, we had that kind of knowledge base to tap into. So those two programs are not really related. They're just the fact that we kind of had that program that had been in operation for 20 plus years, and then we took this and modeled it off of that to build this new program.
And let me just mention so the program, I don't know why, we use the acronym HCP, because it doesn't really mean anything other than, we help families and kids with special needs. And so that funding came through the state health department and has been around for, about 20 years. With COVID, we were very aggressive in trying to get some additional funding related to addressing health disparities because the pandemic illuminated many health disparities. And so, our agency's responsibility is to provide access to care, not necessarily provide the direct care, but our team really does a phenomenal job around navigating the systems and providing opportunities to people to get access, and that is a high priority. So in the realm of funding, the majority of our funding does come from grants. There's federal grants, there's foundation grants, there's many different grants, and I will tell you that one of the things that I'm very proud of is that our agency has demonstrated success year after year in seeking grants and continuing a way to meet our priorities. And so I think that's a very good question around, when does the funding end? What is our plan? But know that we're always forward thinking and related to what our agency's priorities are. And we have a statutory responsibility to develop a community health assessment that provides data, and we work with over 60 different agencies, and then we also develop a community health improvement plan, and we're in the process of that. And one of the key areas is access to care. And so, again, you guys, I just want to commend you all for being here and really appreciate the work that you do, because, 715 individuals in complicated situations, dealing with so many different barriers and challenges, and to get them connected so they're not ending up in the emergency department of UC Health or other areas that are not really intended to support their needs. So I think that you guys are like a utility, public health, just steadily working and doing a great job. And I really greatly appreciate you guys putting together a presentation today to highlight the good work that you're doing.
I'd like to thank you for the impactful work that you're doing and have done. And just wanted a point of clarification. Are you still providing the care coordination for the special needs families? Okay. Thank you. Thank you. Thank you so much.
Any other comments? All right. Well, thank you very much for the presentation. I just want to say the word collaboration has become kind of a buzzword. You'll hear me say this a lot. But when it comes to teams like this one here, it's not a buzzword. It's the way that they do business. They collaborate. They work with multiple different agencies, and all for the benefit of our citizens, and we're very grateful.
Yeah, and I'd also point out, too, sometimes there's resources in the city of Colorado Springs, but not outside of the city of Colorado Springs. And so we take care of the entire county. And then so that's something that this care coordination does as well. It's not specific to, like the city of Colorado Springs. I think that's important. And we have another presentation up, our immunization program, Christy Durbin. We're going to talk a little bit about mobile outreach. And we also have Dr. Albanese on the line as well to participate in the presentation.
Good morning. My name is Christy Durbin. I'm the Immunization Children Manager, and I'm going to talk a little bit about our mobile vaccination. I don't think. Using that team to expand access in our county. All right, so a little bit about our team. So they provide vaccine out in the field, and this is a new capacity that we were able to launch during COVID to really increase access beyond our brick and mortar facility and bring services to where people are at in our community. So they respond to disease cases and outbreaks. They provide vaccine education and outreach, and they really reduce those barriers. They make it easy and convenient to get vaccinated. So one of the amazing things about this team is that we really work at the request of our community. So we have community partners that reach out to us specifically because, it's a partnership that we had developed during COVID, or they've heard about the work that we have done, and we were able to come out and really increase the capacity of our immunization program. So some of you might know that we do have a clinic upstairs that we run 5 days a week, but if we do have a need in the community prior to this team being developed, we would have to shut down operations in that clinic and send our team out into the field. So this mobile vaccination team really increases that capacity dramatically. So next, next slide. So our accomplishments. So this team was mobilized in the summer of 2021, and I want to give a lot of kudos to this team. They're an innovative model that really better positioned us to respond to other communicable disease in our community. So of course we did COVID vaccine out in the field, but we also did Mpox, and then most recently invasive pneumococcal disease. So this team uses a van that we purchased during the pandemic, which is a tremendous resource and really helps our team be more mobile and really vaccinate in any setting. We've been to bars, clubs, churches, schools, health fairs, shelters, soup kitchens, you name it, we can vaccinate in that setting. And we really break down those geographical barriers. So we've gone as far east as Calhan. We have an amazing partnership with District 49. We've been doing flu vaccine with them for years and years. We've gone into Manitou. We have gone as far north as Pikes Peak State College and as far south as Fountain. So all over our really large county, we are vaccinating. And then just some numbers. So these are a couple of weeks old, but since October of 2021, we have given over 6,000 vaccines and done over 114 clinics. All right, and then a little bit about the breakdown of our team. So this team is led by a public health nurse, and then we have a project management specialist that helps with a lot of the logistics, working with our partners. We have 5 part-time public health nurses and 2 program assistants that are part-time as well. One of those positions is currently vacant, and we really use this team to kind of tailor what we need out in the community. So a lot of times the whole team doesn't go out, but sometimes if we need a really robust response, we'll send the whole team. And then this team is funded through a couple different funding streams. So the American Rescue Plan Act, and then Immunization 3 and Immunization 4. Those are grants that run through June of 2025. And then a little bit through our MPOX funding, which goes through March of 2023. So as you can see, the staff that support this team are all funded through time-limited grants. All right, and then the last slide. So future goals. We want to continue to meet the needs of our community, respond to future vaccine preventable disease outbreaks, increase that access, reduce those barriers, and really partner with our community, build those strong community partnerships, because we know we cannot do this on our own. So this team is tremendous, and I'm happy to take any questions.
Christy, first I want to thank you so much for helping us over the past few years. So thank you very much. You know, vaccinated in many settings, including bars, churches, schools, health fairs, shelters, soup kitchens, etc. I have to say I'm a little jealous. I've been giving vaccines in most of these places except bars, so that might be on my bucket list.
Yeah, it's a really flexible, adaptable team, so we love our mobile team for sure. Anything else?
Any other board? General Briggs.
Jack Briggs. I just wanted to also say my kudos. We've been able to benefit at the rescue mission from this mobile vaccine clinic several times, and we're very grateful for that, so thank you.
Yeah, they've been a tremendous partner, so thank you.
So my comment tags on to what Susan just said about the coordination team just prior to your presentation. Your funding is tied to grants, and I'm sure you're always scanning the horizon for when your grants run out, what else is going to be in the future to fund this on an ongoing process. So we appreciate that. That's not always easy to do, and kind of can leave the team feeling a little bit up in the air too when they see the end of the grant coming near. So any information on upcoming grants or anything like that in the future, please update the board, let us know, because we do think it's important work. My last comment is specific to the van. Was that purchased with COVID dollars? And if so, when does that have to be tied to COVID, or can it be used for other things?
We can use it for other things,
Great.
but yes, we did purchase it initially for COVID response.
Terrific. Thank you.
Yeah, I think that we have benefited, in purchasing, as an example, that van. I will say that there was a shortage of different parts where we were going for a Ford van, and we actually needed to meet some requirements, and it's actually a Mercedes. And I have all the detail, on that as well, because of public health and Mercedes doesn't really go together. That's just, the challenges of COVID and getting what we could, when we need it. But going back to the theme of access, our county is so vast as it relates to our increasing population and the landscape that we have to cover. Being able to respond with partners as it relates to prevention activities, specifically when there's an infectious disease concern, of MPOX, and we need to respond quickly with some of our partners, and we do it strategically as it relates to, what are those populations and what can we coordinate. This team has been very adaptable and flexible and have have created some really strong trust bonds in the community. And, one of the things, too, is that we cover the bases, because I know that there's been some concerns about, going out to a school and maybe the kids getting vaccinated without any parent consent. I will assure you that that does not happen with our team. There are parent consent forms, and there are certain requirements that we do not waiver on. And so I really appreciate the level of expertise, but this team is a 2.5 if you're tracking nursing staff. Wanted to call that out because that is an area where we have been having challenges in hiring, but this team has been very stable. But I think it's also like the fun of being in the community and the partnerships and fulfilling the public health mission. So I think that's good news. And we do have Dr. Albanese on the line. Dr. Albanese, if you can provide some insight into how we respond related to different concerns in the community as it relates to mobile vaccination, please.
Sure, thank you. Can you guys hear me okay?
Mm-hmm.
Yes. Okay, perfect. Good morning, everyone. And I do want to share kudos to both of the teams that have presented this morning in terms of community outreach. I know for me, in my position, I have worked closely with both of them. So it's fantastic to have that resource at the agency. So I'm going to tell you a little bit about something specific for the mobile vaccination team with Christy and her group. So I'm going to talk about pneumococcal disease. I actually gave you a little phonetic spelling there to make that a little bit easier. And I'd like to also call out Jessica Calloway and Haley Zachary with our communicable disease program. So we're going to talk about a scenario that we've had since November in our county, and Jessica has been fantastic in terms of tracking it. But let me give you a little bit of background about pneumococcal disease. So pneumococcal disease is a bacterial infection. It can cause as illnesses as minor, relatively, as ear or sinus infections. But really, the attention for today is the fact that pneumococcal infection can cause serious disease, infection of the blood, pneumonia, meningitis, which is infection around the fluid around the brain, cause infection in bones or joints, infection of the heart. So these are serious infections that would typically require prolonged hospitalization for treatment, extensive evaluation in terms of working up the infection, and so forth. Pneumococcal bacteria are spread from person to person through infectious droplets from the nose and throat. So when someone has pneumococcal infection, they carry it in their nose and throat, and then they're able to spread it to another person via close contact, coughing, sneezing, sharing utensils, sharing drinks, sharing cigarettes, things like that can cause an exposure. This disease has been around for a long time and sort of historically has impacted either older adults, which is sort of big in the pneumonia category and the bloodstream infection category, but also I'm a pediatric infectious disease physician, and this earlier in my career, we're going to talk about vaccine in a second, but earlier in my career had a tremendously negative impact on young children, particularly children less than 5 years of age. So a lot of bloodstream infection, a lot of causes of meningitis, a lot of poor outcomes in young children that would have this infection. Next slide, please. Are we on the pneumococcal vaccine slide? There we go. Very good. Thank you. So there has been a vaccine against serious pneumococcal disease since 1977. The adults in the room may recognize this as the pneumonia vaccine. So that's been around for a long time. But that vaccine was not particularly effective for young children. So a childhood vaccination with a newly improved and designed vaccine was introduced in 2000, particularly to focus on the pediatric burden of disease. And in fact, once that vaccine was rolled out in the routine pediatric vaccination schedule, the serious pneumococcal disease in children under 5 years of age declined 93% in the years following use of that vaccine, which is a fantastic success story. And in fact, in my career, I watched this serious disease almost get wiped out in young children, which is incredible. The other incredible benefit, though, of this new vaccine is there was a spillover effect into serious disease in adults. Because when you vaccinated children who carried the pneumococcal bacteria in their nose and throat, the vaccine wiped out, sort of eliminated what we call that colonization. So the children who got vaccinated no longer would carry the strains of pneumococcus that cause serious disease in their nose and throat. And so what are one of the sources of disease in adults? Getting exposed to children who carry it in their nose and throat. So in fact, adult pneumococcal disease also decreased related to the pediatric vaccination campaign. And in fact, starting around 2012, this new and improved vaccine was actually introduced as part of adult vaccination programs as well. So next slide, I'll just show you this a little bit on a graph. So you're just showing the rates of serious pneumococcal disease amongst all ages in the United States since around the 1990s. And you can see that once that new pediatric vaccine was introduced just for children, young children, the disease markedly declined over the course of the first few years. And then the vaccine had been tweaked a little bit for additional strains of the bacteria that were included in the vaccine. And then eventually we have it introduced for use in selected adults that are at high risk for pneumococcal disease. And the disease, albeit a little slower decline, continues to go down. So this is a real success story for pneumococcal vaccine in really a relatively short amount of time in terms of the vaccine world, right? In a matter of 5 or 10 years, we've just seen a dramatic decline in disease. So why am I telling you this story? So in November, our communicable disease program received reports of a cluster of serious pneumococcal disease among persons experiencing homelessness. So this is a whole bunch of persons experiencing homelessness who got serious pneumococcal disease infection, admitted to the hospital, going through the emergency departments, admitted to the hospital in a very short period of time, which is an unusual pattern. Now, pneumococcal disease is more common in the winter. It can be sort of a complication of influenza, as we've also learned potentially of COVID infection, and so we saw this during the pandemic. But it was unusual just to see, what is now is not an incredibly common disease, but a bunch of cases among persons experiencing homelessness in a short period of time. So next slide, please. So this is sort of a graph showing you the calendar dates since November along the horizontal axis, and then the number of people that were reported to us, because this is a reportable condition in Colorado, so they need to be reported to public health. And so you can see that, over the course of 2 or 3 weeks, we had, almost 10 cases of this disease just happening. And so understanding how pneumococcal disease is spread from person to person is important. Understanding the potential environments that persons experiencing homelessness may live in, whether that be in encampments, whether that be in various shelters, just sort of their movement, made us concerned that close physical contact might result in more infections. And again, these are serious infections, bloodstream pneumonia and so forth, bringing people into the hospital, requiring hospitalizations. So we connected with Christy and her immunization team, and we connected with the community partners that provide services to persons experiencing homelessness throughout the county, and said, hey, we have this issue. We are concerned for the clients that you serve. We have a vaccine that works really well. Can we connect to offer special clinics and to encourage the medical providers that these agencies already worked with to saying, let's up the ante and let's get some pneumococcal vaccine offered to your clients so to see if we can disrupt transmission. And so in fact, we've had over the course, since the middle of December, have instituted 5 clinics. These are clinics that Christie's team went on site to the service providers around the county. We offered both flu vaccine and pneumococcal vaccine. And the trend changed, right? There's something different about the right side of the graph compared to the left side of the graph. We had consulted with CDPHE about this approach because we wanted to, make sure that we were, using good criteria to offer it to persons experiencing homelessness. We consulted with CDC. We actually consulted also with the state of Alaska, who of course has a large Native American population. Native Americans are also at particularly high risk for developing pneumococcal disease. It's one of the high-risk adult groups. And in fact, in Alaska, for a couple of years, they have had problems with very high case rates of pneumococcal disease in their Native American population, particularly persons experiencing homelessness. So we wanted to do a rapid response, get out into the community, see if we could disrupt the spread, because we know that the pneumococcal vaccine will reduce the bacteria that you carry in your nose and throat, and hence disrupt the spread from person to person. We'd like to think that this graph just demonstrates a great success story, and really, since the middle of January, we've been good, everybody collectively knock on wood, we've been good about not seeing this pattern continue. So again, tremendous kudos to Jessica and Haley and the communicable disease team for really keeping a very, very close eye on this what we're calling cluster, meaning grouping of illnesses, working very close with all of our hospital partners to make sure that they were reporting cases to us promptly so we understood what was going on. And of course, to Christy and her nurses and her program assistants really stepping up and getting right out there, right in the front of the community to help us with this event. So I'll stop there and see if there's any questions. Thank you.
Questions or comments from the board? Dr. Vu?
Dr. Albanese, thank you. I'm just curious, the pneumococcal vaccines that were administered to homeless population, can I ask you which vaccine that was?
We used PCV20, so that's pneumococcal vaccine is PCV20. So we used the 20-valent. And we did actually, CDC did strain type. The strain type, the type of the strain of pneumococcus that were causing infections, and most of them, and this will be for Dr. Vu, most of them were type 4, not all, but most were type 4, and so the majority of the strains were included in the vaccine, so we were fortunate in that regard.
Yes, thank you, Prevnar 20, thank you.
Any other comments? Dr. Albanese, thank you again for a very detailed report. And Susan, I think you've got one other item to mention.
I do. I did want to mention with over 60 different reportable diseases, our team is always active. There's always investigations that are going on behind the scenes. They stay steadily busy, and with this situation, I think they provided great situational awareness and updates and those kinds of things, and responded very quickly, and so that is greatly appreciated. And again, it's about responding appropriately and providing access to care, depending on what the situation is, and sometimes it seems like we're seeing more complicated situations as we've been through COVID. I have a couple of more items just to mention to put on your radar. I think you are all aware that the SNAP benefits are ending March 1st, and we work very closely with our Department of Human Services, and we have a Women's, Infant, and Children program, which we refer to as WIC. And my understanding is that the SNAP benefits, it's going to be affecting households related to $90 to $95 per month, and we share clients that we serve. So I anticipate that we might gain additional clients with our WIC program that we're only receiving SNAP benefits, and so we'll see how that goes. But also, our care coordinators play a critical role within coordinating the needs of clients, and so they will also help out in this situation when there are individuals experiencing, lack of access to food. So they coordinate with Care and Share and other resources and try to do the best that we can to serve our clients. So I do think that that's important to put on our radar, and as time goes on, we'll see what other effects there are. I also wanted to mention that you have seen, I'm going to shift big here. You have heard or read information in our local media or heard from our Pikes Peak Library District as it relates to the situation going on up north and tests around methamphetamine in some of the facilities. I would like to just assure you that our co-medical director, Dr. Paul Mayer, as well as our environmental health services director and our public information officer, we had learned of some results late Friday, I think, in the evening, and then worked the weekend and on Monday with our partners to provide support. This is not an area where we're going to lead. We don't have jurisdiction in indoor air quality facilities, but we do play a key role in support. So we are a resource to provide information on health risks. My understanding related to the testing that was done, the severity of the risk is low, and we did provide some additional information through FAQs to the Gazette, and working with our School of Public Health on they have a toxicologist that gives some good insight there too. So wanted you to know that we're playing a support role. We are in support of the industrial hygienist, the consultant that they brought on board, and the approach that they're taking, and some of the tests were found in the bathrooms, which those are easily cleanable surfaces. And so that's the good news, but more to come on this. And if you have any specific questions, please let me know. And as we follow along to see this through with our library partners.
Go ahead.
Yeah, thank you. Susan, you bring up a good point. Those are easily cleanable surfaces. I imagine they get cleaned every night. What does that say?
Yeah, and I'll probably bring Dr. Mayer up here, and I guess I should clarify that too, because with the bathrooms and the hard surfaces, those are easily cleanable, and that's where I understand that some of the testing was done. And if Dr. Mayer, you can come up here, and Roy, you might know too. I don't know the level of if they're cleaned every night, but for our bathrooms in this facility, and we clean up multiple times per day, not just morning and night. I mean, it's an ongoing effort, and I would think with such a high volume of individuals, going to facilities that I would assume that they clean multiple times, but I don't exactly know.
Yeah, I think when we talk about when we talk about that toxicity, it's important to remember that when they develop the guidelines are for people living in an apartment or home with that level of methamphetamine contamination. And when they developed them, they imagine worst case scenario. So imagine a 2-year-old child in a diaper, lots of skin-to-skin contact with a carpet. And that's how they came up with the guidelines for mitigation or removal of methamphetamine. And unfortunately, we don't have other guidelines for public spaces where there's very limited contact. So when you take that guideline and you apply it to a place where somebody goes to the bathroom, washes their hands, and leaves, just realize the risk of toxicity is very low in those public spaces. But I'll mention just one thing, if you allow me, that I think one other harm of this that we have to think about is our libraries are disproportionately used by different demographics. And the perception that our public spaces aren't safe spaces is significant. I've been reading a lot about suicide prevention, drug abuse prevention, and a lot of that goes back to feeling connected, goes back to language proficiency, reading proficiency, and how well you do in school and how you're connected. So I worry a lot about the disproportionate effect of people perceiving our libraries as not safe spaces. To me, I worry, to be honest, more about that effect than I do any direct toxic effect of the methamphetamine.
Well, thank you. I've talked to some librarians who work at Penrose. they feel like it's physically unsafe at times also. So, but I appreciate what you're saying. That's
Yeah, and you know
good
that
to keep in mind.
the environment, of course, would change. So if you walked into a bathroom and somebody had just smoked methamphetamine and it was still in the air, that would not be great. I mean, for sure, that's different. And so it's hard to say what the risk is for any individual person walking into any space at any time. You're correct.
Okay, thank you.
To go along with your question, Councilman Donaldson, I think that's a good question. With those facilities being cleaned daily or even multiple times per day, but predominantly it's going to be countertops, urinals, toilets, and floors that are cleaned. But if they start testing walls and ceilings that have not been cleaned, that's where they're going to find those trace elements.
Right, there's some, and our Environmental Health Division, Chief Roy would know more about this, but certainly the mitigation in carpets and drapes is much more difficult. You're right, that's a whole nother matter.
And the current status is that they've conducted more testing through their industrial hygienist, and so that's where we are at this point in time, and there have been areas that have been closed down. No access. But we did want to, go ahead.
I was just going to say that there's also a difference between smoking and cooking. When you cook it, stuff I know now, it gets sticky and it's hard to clean. If you're just using regular cleaning materials, it doesn't clean it up. Smoking it, those particulates might, you'll be able to clean off of a surface. So, we're working with PPLD to figure out for that at-risk population what their options are, as opposed to going to the library. So we're working directly with them right now as well.
Yeah, that's very true, that when they develop the guidelines, they tend to test just for methamphetamine, but that's a surrogate marker for all the other chemicals that are released in the manufacture. And so they had to be very conservative with the methamphetamine levels that were acceptable, realizing that what they're not testing for is all these other chemicals involved in the cooking process. So again, looking at an apartment or a home where methamphetamine is manufactured and coming up with a guideline is very different than a space where it's hopefully almost certain to be true that no manufacturing is taking place. That's true as well.
So that concludes my updates. I just wanted to end with thanking our entire staff. I mean, they work incredibly hard, every day, 24/7, depending on what the situation is. And I wanted to say that I'm thrilled, Glant, to have you on our board. And now we have a full 9-member board, which is wonderful. And I look forward to working with you. And that's all I have.
Any closing comments from members of the board? Seeing none, I will entertain a motion to adjourn.
Move to adjourn.
Thank you, Dr. Terbush. And second?
Second.
Thank you, Commissioner Gonzalez. All in favor of adjourning, say aye.
Aye.
Aye. Thank you. See you next month.